to menopause. So what is menopause? So menopause is a natural biological process that marks the end of a woman's reproductive years. So it is that point in time when a woman has not had a menstrual period for 12 consecutive months. That is very, very important. 12 consecutive months. And normally it occurs around the ages of 45 and 55 years. So, but mark that is very, very important. That 12 consecutive month matters is very important. And the years leading up to menopause is called perimenopause, in which women can have various kind of symptoms. And the average age of menopause in the UK is around 52. So, what's the cause, or what are the causes of menopause? So, menopause is a natural process, as we can imagine, due to natural decline in ovarian function. So the ovary stops producing the hormones. So particularly the ovaries produce the hormones called estrogen and progesterone. And when that hormone production stops, then that then leads to menopause. And also we know that also menopause can be caused by surgical removal of the ovaries. So what we call the ovarectomy. This can be because of some factors. So let's somebody has an ovarian cyst or ovarian cancer, or you are removing the ovaries for whatever reason, then that person can then go into what we call a medical menopause. So that means the menopause that is caused by medical intervention. So that can also happen. And also menopause can be caused by treatment. If somebody has got a cancer for whatever from whatever so just say for instance, someone has got treatment for cancer, chemotherapy or radiotherapy, that can affect the ovaries, in which case that can cause menopause as well, or menopausal symptoms. Okay. And also we have what we call a premature ovarian insufficiency. This is when if somebody undergoes menopause, or if the menstruation ceases before the age of 40, and that can happen also naturally, but we call it premature ovarian insufficiency because normally that is coming about 10 years early. So that also can be a cause of menopause. So what are the symptoms typically that can happen with menopause? So let's look at the menstrual cycle, what happens with the periods. So the periods can then become so in terms of the menstrual changes, so we said menopause is when there's been no period for 12 months. So but before then, there can be some menstrual changes before premenopause, before the menopause happens on its own. The periods can be irregular, or can be shorter or longer cycles. There can be a change in the cycle just before menopause, and it may become also lighter or heavier just before everything then ceases or stops eventually. And also even before the diagnosis of menopause, there could be some what we call it vasomotor symptoms when when women have hot flushes and night sweats. Just wondering that you sleeping, and then you want all the windows to be open even when the temperature is very, very cold, or you wake up in the night and then the bed sheets are all wet with sweat, or your pillows is wet with sweat. And you're asking your your husband what's going on. This room is very hot, but whereas is just the signs of menopause, really. And also you have psychological symptoms, and that could also involve mood swings, anxiety, depression, irritability. Somebody who's been functioning well before, somebody who has not had any mental health issues before, then you suddenly become irritable, depressed, and anxious, and that can point to symptoms or signs of perimenopause or menopause as well. And then you have memory issues or difficulty concentrating. People call it memory fog, and this can be very, very distressing, particularly for somebody who's very high functioning executives, in which case maybe you're a leader at work, or even your family, you just found yeah, at work majorly, really just found out you have difficulty concentrating, recalling information. I've seen patient that described to me as memory fog. Is very can be very debilitating. So that can also be a pointer to menopause. Also, talking about sleep disturbances. So you can have insomnia or disrupted sleep pattern. So somebody whose sleep has been very one excellent before, you don't struggle with sleep. Suddenly you find that you can't sleep, or you're having to wake up in the night and your sleep pattern is being disturbed. Also, you can have genitourinary symptoms. You can have vaginal dryness, itching, or discomfort during intercourse, and increased risk of urinary tract infection or incontinence. This can be also pointed to menopause or perimenopausal symptoms. Looking at bone health, at time of menopause, there's decreased bone density, increasing the risk of osteoporosis. And that is why in our age, in women who have undergone menopause, one has to be very careful. Women in their 60s and 70s, yeah, we have to be careful with them, making sure that their they look after their bone health. At that age, 60, 70, there's increased risk of fall. And if somebody fall at that age, and then there's fracture to the neck of femur, is one of the increased risk of mortality among that age group. In which, if you have a fracture of neck of femur, then the mobility is compromised. Even with operation, the quality of life is not never the same after that. Okay, what are the other symptoms of menopause? Some patients have reported weight gain, fatigue, their hair thinning, and skin changes. So there's a variety of symptoms really that can happen at menopause, or even just before leading to menopause, what we call perimenopause. Right. So coming to diagnosis. So how do we make a diagnosis of menopause? We've said before that the diagnosis of menopause is what we call a retrospective diagnosis, in which case, if there have been 12 months, consecutive 12 months in which there's been no periods at all, then when we look back, we then say, okay, this woman is now post-menopausal, is now gone through the change, or she's menopausal. And like I said before, that even before that period of time, you can have those symptoms, what we call it perimenopause as well. So that can be few years before the actual menopause happens. Okay, but there are tests that we can do to check whether menopause has happened. The major one we do is what we call the FSH test. That's the follicle stimulating hormone, in which we check two levels 3 months apart. So if the levels are over 30 milli international units per mil, then we can then say definitely the ovaries are not, they've gone through that change, and then we can say this menopause has happened. Also, we can check estradiol levels. This is just checking the estrogen level, really, and a reduced amount of estrogen can also confirm or can support a diagnosis of menopause. So I'll just run through the management before then, but I'll focus later on HRT after the interval. So let me just run through the management really. So how do we treat menopause? So how do we know it's part of life. It's just one of those things that happen, and it's about how we react or how we respond to it, or how we. I don't want to use the word enjoy, because it's not something that you enjoy in that sense. But how do we? Because it's part of life, is what will happen to all women at some point. So you just have to be plan. You can plan towards it and make sure you're in good health before leading to menopause, and then also carry on. There's things that you can do. So let's talk about lifestyle modification. Talking about healthy diet, rich in calcium and vitamin D is very, very important. So, I mean, we know vitamin D is very important in this country because we have very reduced amount of sunlight. Yeah, it's not as sunful as African country where a lot of us came from, or we have our family ties. And if you're not lucky to be in the Middle East or in Dubai or something where there's plenty of sunshine, so or in Spain or something, so in the UK the sun is not that much, so you have to supplement with vitamin D if you can, and also doing regular exercise to maintain weight, bone health, and cardiovascular health is very, very important. Also, we should avoid triggers for hot flushes. So avoid things like caffeine, alcohol, or spicy food. I know Africans, we love our spicy food. Um, so let's just be careful. So you can reduce. I'm not saying you should not take spicy food at all, but if you are having symptoms of hot flushes, so you know that the spicy food is going to make it worse, so you can tone down on your spicy food if you can. Then also talking about hormone replacement therapy. I'm going to go into detail in that in a minute. So HRT works. We know it works. We know it's safe. It helps to reduce hot flushes, vaginal dryness, and bone health. And also, but we know that there are potential risk to breast cancer, stroke, heart disease in some women. We'll talk about that in a minute. So, um, also, we know that there are non-hormonal therapies. What do I mean by that? There are some tablets that we can use that they are not HRT, they are not hormone, they are non-hormonal. So these are tablets we classify as we call them SSRI or NSNRI. So sorry, I apologize about the technical terminology. So these are serotonin and no adrenaline reuptake inhibitor. Um, I know some psychiatrists are in a midst, so they know what I'm talking about. So we can use it for the mood symptoms and hot flushes. It does work. Example of those tablets is what we call one is called trade name Velavaxine. We know that can be used for mood symptoms or hot flushes. And also, we know we can prescribe vaginal lubricants or moisturizer for vaginal dryness, just to help with that side of things. Because don't say, even though you might have reached the age of menopause or you've gone through menopause, it doesn't mean that your sex life should stop. There are things you can do to help in that sense. And I know we are looking after ourselves and also looking after our partner as well. Or yeah, because you can't just say, okay, things are not things are difficult. You're not enjoying intercourse, and that's it. No, you have to find the solution so that your partner, your husband, can benefit as well from that point of view. I won't say too much along that lines at the moment. Okay, so what about alternative therapies? I must sound a note of caution that you should check for safety and side effects of these alternate therapies. Some studies have said herbal remedies such as black cohosh and soy, so flavons can help. I think you can get this from some shops that they sell herbal remedies. Like I said, check for the safety, check for the side effects before you use it. Personally, I won't recommend it, but some people have explored that and they said they have some benefits. Also, cognitive behavioral therapy can be used for mood disturbances. This is just in terms of talking therapies, just to help with the mood disturbance. So that can help as well. And preventive care. So monitoring our cardiovascular health and also you can check regular checks about blood pressure, doing ECG if we need to do that, and then also checking bone density scan. Doing bone density scan can also help, particularly if there's a family history of osteoporosis, or if we think that there's a risk factor there for osteoporosis, then one can do bone density scan, or ask the GP for that, so they can check on our bone, on the health of the bone. That can also be done as well. That's a proactive way to look at that. Okay. So what are the long-term risk for of menopause if nothing is done? If we don't do anything about it, if we just, so once you reach the age of 52, the period stops, and then you do nothing. So we talked about osteoporosis. This is very, very important, and this is because of the declining levels of estrogen. Estrogen is very important for bone health, so that can cause thinning of the bones. That's the osteoporosis, and this can lead to risk of bone fracture, falls much later in life. So it's something that we need to take care of. What about the cardiovascular disease as well? This can increase after menopause, in which women can also have heart attack. So it's not only men, or it's not only obese men that have heart attack. Women, this can happen to women as well. And there was a study to say that if not being careful, if we're not careful, we're not taking women seriously if they present with symptoms of heart attack, because we don't associate heart attack with women. But if somebody's in the menopausal age and presents with chest pain, right-sided chest pain, and symptoms of heart attack, one should take that seriously. So, but to prevent that, you have to then think about how do you manage that, how do you prevent, how do you improve your cardiovascular health to prevent having heart attack. That will not be our lot or portion, in Jesus' name. Okay, so out of cognitive decline, we're talking about memory loss, dementia, brain fog. So these are the long-term risk with menopause, and we can do something about it. Okay, so just to tell you about the long-term risk, if we don't do anything with menopause, the cognitive decline can happen. So for anybody for anybody having any of these symptoms, if they're affecting you, if they're severe, if they are interfering with your daily life, I think you should seek help. Speak to your GP. Don't be put off by all the media campaigns against HRT, or all the things you read, or all the things you've been told by your sisters, your mom, your daughter, depending on your age group, by your friends. Seek help. Seek help. Seek the right help. Okay. Also, you should seek advice if there's concern about your long-term health risk, particularly if you have risk factors for dementia, risk factors for osteoporosis. You should seek help, proactively look after yourself. Also, you should seek help when you have symptoms like abnormal bleeding, severe mood swings, or significant pain. So someone who has not bled, who has not had a period for 12 months, and then you now bleed, that is what we call post-menopausal bleeding. That is abnormal. You need to see your GP immediately. Or if you have bleeding after intercourse, it's not normal. You should always flag that to your GP. So it's better for you to raise the alarm or to speak to your GP than to keep silent, and then, God forbid, something is coming up that is not going to be nice. So it's better to speak to the GP, okay, and get assessed, get checked up. Okay, so I think I will stop at the moment, and then we'll then come back to discuss HRT. Is that okay? Yeah, thank you.
Okay. Yeah, I think we can take a few questions. Also,
Okay, should
just,
I stop sharing or I should just leave it there?
you can leave it. You can leave it, sir.
Okay,
Okay. I've got a few, well, I've got quite a number of questions that I would want us to go through. I know some of them you have kind of mentioned in your presentation. However, we have people that, joined during the course of the presentation.
okay.
Now, I'll start off with this one. It says vaginal dryness is common after menopause. Is there a water-based or oil-based lubricant advisable?
Okay, so yeah, there is, but we discourage using oil-based lubricants. We prefer water-based ones, and then there's lots of non-hormonal based ones. So simple things like Replens or Silk can be is available available over the counter.
Sorry, Dr.
I
Ajayi.
was going to
Are
type
these
the
available, all around the world or
yes, yeah. It may not be the exact trade name, but I'm
okay.
just putting something on the chart. Replens and Silk. If you're in the UK, you can just get this over and can ask the pharmacist, or check in the pharmacy.
What about for the participants from abroad and obviously from other countries?
Um, yeah, because of the trade names, I'm not sure. But let it be water based, not oil based.
Okay.
Water
Okay.
based vaginal lubricant is better.
Okay. Thank you very much. Another question I've got here says, is the age of menopause different for other women in other countries? For example, in the US, Canada, or, in African countries. Is the age of menopause different or is it the same all across the globe?
That's a bit tricky. It's tricky because I think it's changed a bit in the last few years. So because I live in the UK, I work in the UK, so I can only quote UK figures. I will pass on that. I don't know. But I would probably say it's similar, really.
Okay.
Yeah.
Okay. Another question I've got says, what can a woman do if she is approaching the age of menopause but has no children yet and still hoping to conceive? Can menopause be medically delayed? Do you want me to read the question again?
Oh my God! You know what came to my mind? I was going to say what God cannot do, can does. Sorry for the. I know majority of us are Christians, so that's why I'm just trying to use my Christian. But to be putting my gynecologist hat on now. To delay menopause, I think that's is not possible. Is a natural event.
Okay.
Just when we are born, just part of life. You can't. I don't think you can't delay menopause.
Okay.
Unfortunately, no.
Okay.
That is
Um,
why. That is why it's better. That's why. What you can do in terms of, I mean, as a young woman wanting a family, don't you have to make some decisions, make some good life choices. Don't delay having family at the expense of. I know we need to progress in our career, be happy and things, but don't delay things. Do the things you need to do at the right time. Yeah.
okay. Thank you.
Okay.
I've got another one here. It says, are there recommended multivitamins? Is there anything you can recommend for maybe women over 50 or perimenopausal women? Are there multivitamins? Because you've said so many things, check your bone density, your bone
Mhm.
health, you've said a lot of things that needs to be going on in the background. Are there
Yeah.
any recommended
Yeah.
multivitamins?
I put I put in there vitamin D is one I would recommend for the bone health. And
Okay,
then healthy diets. We've talked about healthy diet. We talked about the vitamin D. I think that is very, very important, and particularly in the UK, I mean, our sun is not very in much abundance in that sense. So you can also take calcium supplement as well. That's very good as well. Calcium supplement, vitamin D, avoid alcohol, yeah, things like so. Just normal healthy lifestyle, avoid smoking, things like that. So not just normal regular things that will do will be very good.
okay. Right, I've got some more questions.
Okay.
This one says, "Why am I adding weight even though my eating is the same as before? Why am I adding weight even though my eating is the same as before?"
Okay. I mean, a bit of background. I mean, is this person, has she undergone menopause or is it around that area of menopause?
I would think that this is around the area of menopause.
Okay, perimenopausal. I
Yeah.
mean, and also depends on is this person on some medication, which might be is it what is causing what the person is thinking is causing the weight gain. So it's difficult. I mean, we need to explore a bit more around that. I know that some patients when they are placed on HRT or when they are put on the pills. Okay, so just take, for instance, the normal contraceptive pills. So we're even not talking about menopause now. We're just talking normally now, general person who does general woman who doesn't want to get pregnant, and then they are put on some hormonal contraception. Some people find the progesterone only any progesterone component. They say the causes weight gain. So it's very different with different people. Some are fine with it. Some it causes a bit of weight gain. So it depends. But I would say make sure that your diet is fine, is rich, is healthy. Watch your weight, and just keep an eye on things. And exercise is good.
Okay. Now, this one says, "What should I discuss with my partner about menopause?" So if we want to look at it from, what should the wife be discussing with her husband about menopause? Maybe now
Mm.
from the husband's angle of what does the husband need to know about menopause so that he can help his wife. So this one is a two-part question. What should I discuss with my partner about menopause?
I
Apart from
suppose,
them coming on a program like this.
yeah, I suppose it's about all the symptoms that we talked about before as well, particularly the psychological symptoms. So the mood swing, the irritability,
Mm,
because that can have a massive impact on the husband, because this is somebody who is loving, gentle, and kind, and then suddenly it's as if there's a 360-degree U-turn and change, and then
mm,
you're wondering what's happening with this person. Somebody who's never been anxious or depressed or feeling low, and then suddenly showing all those tendencies, and then memory issue, difficulty concentrating, memory fog, brain block, and then the impact of night sweats or hot flushes can be severe. In which case, you are sleeping in the same room, it's freezing cold, and then your wife is saying, oh, "Can you open that window?" And then the guy is almost freezing to death, as in not well. Let me not exaggerate. Not as in, you know what I mean. So those are. But if the man's know that, oh, okay, is that age, and then my wife is actually having menopausal symptoms, then he'd be more sympathetic, he'd be more willing. And also the issue of, so also I didn't mention this specifically. Some women have reduced libido. Libido means their sexual drive is actually goes down during menopause, and that can be due to a lot of factors. Factors Majorly along that line of reduced sexual drive, or maybe they just find intercourse not as pleasurable as before, because vagina is dry, things are not as they used to be. So I'm sure the woman will just be thinking, what's the point? But then the man is waiting and watching and praying and hoping that things will happen. So those are the dynamics. Those are things that needs to be discussed. So if the man knows that, if the husband knows, okay, this is what is going on, then they'll be more sympathetic, and then you can deal with it together as a team.
mm, mm.
Yeah. So I think that's the understanding, the empathy, yeah. If the more he knows the what is going on, the better.
Okay. Okay. Thank you very much.
Okay.
I've still got a few more questions. I've got one here that says, you mentioned SNRIs like
Yes. Yes.
venlafaxine.
Yes.
which
Yeah.
comes with cardiac side effects. How do we balance this?
Okay, that's very good, very good. That person has done their research. So I think we're going to come to that in a short while when we're talking about HRT. So before anybody prescribe any treatment or any medication, so normally you go to your GP, they do a thorough assessment. They do an assessment, check there are no risk factors. They check your baseline blood pressure, pulse, and those kind of vitals. Check your family history. Check all your baseline before they then recommend that, okay, let's go, let's use this, let's use that. So in terms of the side effects of those medication, that needs to be discussed with yourself and the medical practitioner, your GP majorly. And then following the review, if we feel that the benefit is more than the risk, then it will be prescribed. But if we feel that the risk is more than the benefit, then we might be looking at other options. We might avoid that particular one. They might try another medication for you. So there are a lot of options. Clonidine is there as well. It's not just for the vaccine. Clonidine is not part of the SSRI and NSRI. It's just another. So there are different levels of medication that we can use that they are not HRT. We're going to come to that in the second part of the presentation.
Okay. There's another part to that question. It says, what are the implications for sleep with menopause?
Right. We've talked about the disturbance, sleep issues, in disturbance in sleep or insomnia, which is when you just lay on the bed and then you can't sleep, and it can be very, very debilitating. Yeah. So it's I mean, from my point of view, I would say if this is just purely menopausal symptoms, I think discuss with your GP, and then after consideration, then they might be to help you select a good HRT. And if the insomnia is linked to menopause, starting on the HRT should relieve that insomnia. But if the insomnia is not relieved, then we have to look at other causes of what is causing insomnia. I mean, look at the stress. Is there any stressful event going on? Is there any problem at home, marriage, finance, any other stressful event? So I think you have to look at take a holistic approach to managing insomnia. What I will advise people not to do is to start self-medicating, to start buying sleeping tablets over the counter. I think it's very, very dangerous because we know that sleeping tablets can be very, very addictive. So we have to actively discourage that. Yeah.
Okay. Still more questions. I've got one here. It says, is it only the absence of menses that tells of the signs of menopause, or is it coupled with advancement in age?
That's a very good question, because we know, even though we said average age of menopause in the UK is 52. I remember seeing a lady in my gynecology clinic. I think this lady, she's 59. She was 59 at that time, and she was still having periods, so regular periods for that matter. So, and also, things tend to run in families. So, that kind of patient, if you trace maybe the mom or the grandmom, it might be that they finished their periods very late. So, in as much as we said the average age of menopause is 52, it doesn't mean that for everybody it's going to be 52. Some might come a bit earlier, some might come a bit later on. So, but the main thing is that if you've had 12 months in which there has been no periods at all, 12 consecutive months in which there has been no bleeding at all, then that person has undergone menopause or undergone the change.
Okay. Another question. What can I do to reduce menopausal symptoms?
I think we've talked about some of it before. Some of it, we mentioned about lifestyle modification. We talked about exercise, diet, reducing triggers for hot flushes. Yeah, I'm there now. So HRT. So this second part. So HRT. What is HRT? HRT is a treatment used to alleviate symptoms of menopause by replacing the hormones that the ovaries no longer produce, primarily estrogen, and in some cases progesterone. So we're talking about majorly estrogen and progesterone. Okay. And HRT is highly effective for managing symptoms like hot flushes, night sweats, mood swings, and vaginal dryness. And it also helps in preventing long-term complications like osteoporosis. We've talked about that. Osteoporosis, that is the thinning of the bone. So HRT should be individualized based on symptoms, age, medical history, and risk factors. Just like we were mentioning in the question. So it's a personal. So before a woman goes on HRT, you have to see a medical practitioner, your GP majorly, and then we go through all the symptoms, go through your medical history and your risk factors. Okay. And once you've commenced on HRT, once you've been prescribed HRT, there will be a regular review, ideally between every 6 to 12 months, really. Most at times when we start HRT, I think normally you have the 3 months check initially, and if everything is fine, if everything is going well, then there'll be a 6 months review, and if everything is going well, then that can be then reduced to 12 months review. Generally, benefits outweigh the risk in women under the age of 60 or within 10 years of menopause onset. So that's very, very key. If your woman is under the age of 60 or within 10 years of menopause, the benefits of HRT generally outweighs the risk. Sorry, this is a very tiny slide, but I hope you can see it. So what are the types of HRT? So we have the estrogen only HRT, estrogen only HRT, and this is used for women who have had hysterectomy. Hysterectomy is when we do a surgical procedure to remove the uterus. So this could be due to maybe somebody has got a woman has got fibroid, a woman has got heavy menstrual bleeding that has not responded to other treatment. So if we do a hysterectomy, so we can then so most time when we do hysterectomy, we do tend to remove the ovaries as well. So if that's the case, then that woman would then need a HRT, and you can just give the estrogen only HRT. But if a woman has got a uterus intact, in which case she has not had hysterectomy, they will need a combined HRT. So combined HRTs mean HRT with the estrogen and the progesterone. It has to be combined. That's what we call combined HRT. And the reason for that is that the progesterone part of the HRT will be what will protect the lining of the womb, which is the endometrium, to prevent the risk of endometrial cancer. Because normally what happens is that if you give estrogen only in a woman who has got a uterus without the progesterone part, so what happens is that the estrogen will make the lining of the womb to keep the cells will keep regenerating and regenerating, and then that can then lead to potential cancer in the future. Yeah, so we give the progesterone to balance to reverse that effect. So if a woman has got uterus, you have to give a combined HRT. So if the symptoms is just more of the vaginal dryness or dryness, you can just give a local vaginal HRT. So that this could be estrogen cream or pessary or ring, which can be applied very locally there. The other type of HRT we can use is what we call tibolone. Tibolone is a synthetic hormone which has estrogenic, progesterogenic, and androgenic effect. So about the medical terminology, this is just saying that it's got a lot of advantage, a lot of effects to help with the menopausal symptoms and also to improve bone health. So how do we give HRT? What route, or American we say route in terms of how do we apply HRT. Once we've chosen, okay, once we've found out, this patient will benefit or this woman will benefit. So we can the way to take HRT is through the oral, through using oral tablets, very common way. This is convenient, but it may carry slightly higher risk of blood clots. Okay, so also we can HRT can be used as a transdermal patch. So that is when we put a patch on the skin, or it could be a gel which is rubbed on the skin, or like a pump as well, pump pack which is rubbed on the skin. So these are all transdermal application. So this lowers the risk of blood clots, um, because it bypasses. The way it works is that it doesn't go through the liver. The way it's absorbed in the bloodstream, and it gives also more stable hormone levels as well. Also, we can deliver HRT through implants, which will be delivered over a long period of time. So implants can be an example of that would be the Mirena coil, which is the like the like a progesterone part of the HRT. So we can put in a Mirena coil to help to as a progesterone part of HRT, and then that woman can then be placed on estrogen tablets or patch to complete the combined HRT method. Also, we can use vaginal rinse, cream, or tablets for relief of genitourinary symptoms. If it's just majorly vaginal dryness, and that can be prescribed in that way, and that can be applied locally with very minimal side effects. So, what are the benefits of HRT? Like we were saying before, HRT does work. Don't suffer in silence. If you think you need to go on HRT, have a very, very open discussion with your GP. Like I said, forget about what you've been told, what you've heard in the past, what people have told you. Yeah. So just go with the facts, go with the truth, be knowledgeable, do your own research, and then go and speak to your GP. So what are the benefits? So number one, benefits relief of the menopausal symptoms. It reduces hot flushes, night sweats, mood swings. It helps with the bone health. So prevents and treats osteoporosis by maintaining bone density. We talk about the osteoporosis meaning thinning of the bones. So that HRT will reverse that, and also it's good to protect the heart. So it will reduce the risk of of a woman developing a heart attack. And also it improves vaginal dryness and reduces the risk of urinary tract infection. So if things are getting difficult from the sexual point of view, in which things are not as good as they used to be, it might be time to consider a topical HRT to be used vaginally. Right. So this is very, very important. The talking about the risk of HRT, and I think that is the one that puts most people off because of what has happened in the past. I think some years ago there was this campaign in the papers about HRT being very bad, very very the killer pills and things like that. So, but we now know that more research has come up, more research has highlighted to us that HRT, if it's used properly with in terms of if there's a discussion with a medical practitioner and the discussion of the risk and the looking at the risk factors, if it's prescribed very very well, actually the risk is actually very very low. Let's look at the risk now. So number one risk is the risk of breast cancer. So they said there's a small increased risk with long-term use of combined HRT. Combined HRT being the one that has estrogen and progesterone. So a small increased risk, very, very small increased risk. Okay. And then also we know that if you're on estrogen only HRT, the risk of breast cancer is even lower. So this risk are very, very, very small. Okay. So and particularly if you've had hysterectomy and you're just on the estrogen only one, it carries a very lower risk of breast cancer. Let's talk about the risk of venous thromboembolism. That's the risk of blood clots. We know that if you are taking your HRT by tablet, there's a slight increased risk of blood clots. So using it by patch transdermal options are safer. So if you want to reduce the risk of blood clots, they might want to start you on the estrogen patch. Yeah, so that's safer. What of the risk of stroke and heart disease? They said the researcher said there's a slightly increased risk with oral HRT in older women or those who start HRT more than 10 years after menopause. So imagine, if you remember one of my first slides. So if you are less than 60, or if you use HRT within 10 years of menopause, then the benefit is more than the risk. But if you are older than 60, and you are using HRT more than 10 years after menopause, then that risk is increased. Risk of stroke or heart disease. The risk is still small, but it's slightly increased. Also, looking at the risk of endometrial cancer. This is the cancer of the lining of the womb. We know that this is increased, particularly when somebody is being prescribed estrogen only HRT. But I doubt there's any doctor in the UK that will do this, because if a woman has got a uterus, we will always go for combined HRT. So this should not happen in the UK, because the guidelines are clear. So if somebody has got uterus, if someone has still got the womb, and they need HRT, it has to be a combined HRT. So that risk is almost eliminated, because nobody will give you estrogen only HRT if you still got your uterus. So what are the contraindications? So if you got all this condition or any of this condition, then HRT be a no. So somebody who has got a history of breast or endometrial cancer. Endometrial cancer is the cancer of the lining of the womb. If you have been treated for that, or if you have that, then you won't be a candidate for HRT. If you've got uncontrolled hypertension is raised blood pressure, then that HRT be a no. If you've got previous venous thromboembolism, that's if you have got previous blood clots, then that'll be a no. Or if you had stroke in the past, that'll be a no. And also if you got an undiagnosed vaginal bleeding, so that'll be a no for HRT. They need to find out why you're bleeding. They need to find out the cause of the bleeding and sort that one out first before HRT can be prescribed. And that is why. So I know we're talking about HRT now. We talked about the HRT and the types and the other things, and the various forms of HRT. So let's go to the alternatives to HRT. Perhaps, I know we discussed this in the earlier presentation. So perhaps people might want to start from these ones to see what are the alternatives first, to see whether they can use the non-hormonal HRT first before going on HRT. So what are the non-hormonal treatments? We talked about the SSRIs and SNRIs, the venlafaxine as an example, to manage hot flushes and mood symptoms. So if a woman has got majorly symptoms of hot flushes and mood swings and nothing else, so in that situation, I think going for the SSRIs or the SNRIs can be a good way to start, instead of jumping to the hormonal HRT, to the HRT, which is hormone replacement therapy, the estrogen, the combined HRT, or estrogen only if the patient has had hysterectomy. Okay, so if the symptoms is majorly that of vasomotor symptoms, such as sweating, hot flushes as well, night sweats, or intense heat. So we can use things like gabapentin or clonidine for that. That can be tried. This will be started by the GP after full examination and discussion. Okay, so this is very, very important. Things like lifestyle modification, we talked about it, regular exercise, healthy diet, stress reduction, avoiding triggers for hot flushes, and things like spicy food. Africans, we know we like spicy food, so we need to be careful of that. caffeine and alcohol, stress. We need to manage things properly. And then talk about the complementary therapies, things like the soy, that's the phytoestrogen. So soy, these are estrogen that can be obtained from food, from plants. Black cohosh, like I said before, check about the efficacy, about all the safety and the side effects before you start on those. Do your research properly. And it's been said that acupuncture might help as well. And but the effectiveness of that varies. So you need to check that before you commence on those treatments. So how do we do monitoring and follow up? So before I mentioned before that before HRT is prescribed, whether alternatives to HRT or HRT itself is prescribed, there'll be a risk assessment. The GP will take your history, medical history, check your vitals, the baseline, your blood pressure, your pulse, everything like that. It has to be checked to make sure that there's no contraindication to starting on HRT. So also there is a need for regular assessment of symptoms, side effects, and the risk. And there's something that we were taught during training in terms of that HRT should be used as the lowest dose for the shortest possible period of time. So you can start on HRT now. Maybe let's say you start in this year, and then in the course of the year, you do some lifestyle modification. Things are great, exercise. You're taking your vitamins, and you feel that okay, you're actually fine, and you think you don't actually need HRT again. So you can come off the HRT and then see how you go. So just because you've been prescribed HRT doesn't mean you have to take it for 10 years. No, you can try to take it. You can try to go off it if you think you don't need it anymore, and you can then adopt the other lifestyle modification. And so take it for the lowest dose for the shortest possible time. That'll be my advice. And also you have to make sure that you go for your annual review, or it could be every 6 months review to evaluate the continued need for HRT. And this is done with your local GPs. And if you live in the UK, everybody that lives in the UK should have a GP. If you don't have one, please get one. Get registered with a GP as soon as possible. In fact, just make that phone call tomorrow. If you're hearing me today, you're living in the UK and you don't have a GP. Even if you live in other parts of the world as well, even in Nigeria, I know there are family doctors, family physicians abound, qualified physicians abound. You can register with them as well to get assessed. If you live in Canada, if you live in US, there are family physicians that you can register with. Please, it's very, very important. Do that as soon as you can. If you have not registered with a GP or a family physician, that's very, very important. And yeah, and that takes me to a good conclusion of our talk today. So thank you very much for listening. Thank you.
Thank you very much, Dr. Ajay.